be welcomed than with a gift. And I walked in, and I have a very sweet Miss Dabney that I've seen that gave me this very sweet gift. So thanks for having me. For those of you that I don't know, I'll just tell you about my background a little bit. I worked for 8 years for Dr. Charles Portera Jr., who was a surgical oncologist in town, and I kind of focused on breast and melanoma. So I did a lot of survivorship care, seeing patients that were newly diagnosed, talking, crying, getting people through. And when he decided to relocate last year to Alaska, I had become fairly good friends with a colleague, Dr. Brooke Daniel, as many of you know, and she gratefully hired me last year, and so I'm in the medical oncology field. So tonight what we're going to talk about are some of the new oral therapies. As many of you know, there's lots of new therapies that are going on in breast cancer, but Tanya indicated that a particular interest for you all were the new oral therapies. So that's what we're going to focus on tonight. If you guys have questions at the end of some of the other new research therapies, I will be glad to tell you what I know. And I'll tell you, I've been at Tennessee Oncology for a year, so it may not be quite, what some of you may have seen as far as what's going on at Sarah Cannon, but I'll be glad to answer some additional questions. So tonight, the oral therapies that are new, that have come out in the last couple of years, are in the treatment of metastatic breast cancer. I'm not sure what the population is tonight, if there is anyone dealing with metastatic breast cancer, or if many of you are still in the adjuvant phase, where you're still going through chemotherapy after surgery. But that's actually what we're going to kind of focus on tonight, because that's where right now all the research is going on, which is exciting. Patients are living longer. So the new oral therapies for the treatment of advanced breast cancer are really two that have become approved in the past couple of years. The first is Everolimus, which is called Afinitor, is the brand name, and it was put out by Novartis last year. And the brand new one is the Palbociclib, or Ibrance. It is produced and was researched by Pfizer, and it was just approved in February. So these drugs are, how's the feedback? Kind of bad? You guys okay? Am I good? Both of these drugs are indicated for metastatic hormone receptor positive breast cancer that's HER2 new, not overexpressed. And both of these drugs are used with hormonal therapy. So hormonal therapy, as many of you all know probably, is used for patients that have hormone receptor positive breast cancer that have not recurred, that essentially is trying to prevent a recurrence, but is also used for folks that are metastatic, to actually keep the disease at bay until there is progression. The question is, why do these drugs stop working? And that's what these companies and these drugs are trying to address. As we see often in metastatic hormone receptor positive breast cancer, oftentimes endocrine therapy alone works for a while. However, progression on endocrine therapy in patients that have metastatic breast cancer is something 100% of patients will face unless their survival is shortened by another medical condition. The time from initiation of endocrine therapy that started, and does everybody know, you can shake a head or just give me a little note, do we know what drugs I'm talking about in endocrine therapy? Okay. Endocrine therapy is tamoxifen, Femara, Arimidex or anastrozole, or Aromacin or exemestane. So, as we know, tamoxifen can be used in premenopausal and postmenopausal women, and the aromatase inhibitors, which are Femara, Arimidex, and Aromacin, can only be used in women that are postmenopausal that are not producing ovarian estrogen still. So why do these drugs stop working? Why does, for some reason, the cancer become smarter than the therapy in patients that have hormone receptor positive breast cancer? Because some folks, we see it work great for years, honestly. We have, Dr. Daniel has patients that have been on Femira alone for 2 or 3 years for their metastatic breast cancer and haven't had a single event of progression. And then we have some that progress within a matter of a few months. So I want you to look at this slide, and we see the downhill. It's kind of scary because at first you say, ooh, you know, survival, this is a scary slide, but really it demonstrates progress. First of all, I'm going to tell you about the drawback to this slide. Dr. Daniel actually sent this to me, and we talked about it. This was put out in 2004. There's been leaps and bounds of breast cancer treatment in the past 10 years, so I anticipate if they did one for 2015, that top curve would go even higher. But I'm going to put the microphone down just a little bit, just so I can kind of show you guys something.
So if you look at this graph right here, this is the percentage of patients that are still alive with metastatic breast cancer. And as you see in 1974, at, let's say, 2.5 years, it was less than 20%. Okay? And you go forward to, let's say, in a solid 3 years, in 2000, 60% of patients are still alive. So this graph just basically tells us how much longer patients are living with breast cancer metastasis, and it has to do because there's a lot of drugs that are coming out. So I think this demonstrates hope that we have patients that are living for years and years. So, pick my microphone back up. So when we talk about
Endocrine resistance. So endocrine resistance is when our good old tamoxifen, Arimidex, stops working for the cancers. Okay? So there's 2 different types. The first one is less common, and it's known as de novo or intrinsic resistance, and it basically means that they don't ever work. Basically, a patient is put on these drugs, and we do a scan in 3 months, and we see that the cancer is growing despite their hormone therapy. These are generally patients that have hormone receptor positive breast cancers that have more aggressive features, such as inflammatory breast cancer, your high-grade 3 aggressive pleomorphic lobular cancers that the pathology report, your doctor says, you know, we're going to go ahead and tell you this is a more aggressive type of breast cancer. So these are the higher-grade cancers that just, most of the time, we have to do traditional cytotoxic chemo up front pretty quick. Acquired resistance is the more common issue we run into with endocrine therapy and metastatic breast cancer, where basically patients do great on these drugs for a while, but then suddenly they stop working. You know, they'll be on Femira for a year, and then we do a scan a little after a year from diagnosis, and we see new lung lesions or new bone lesions. So the acquired resistance is really what these drugs are hoping to help. And it is an issue because 40% of patients do progress within the first 3 months. And a lot of times it's just trying to find the right treatment of it. It doesn't mean necessarily that their days are numbered when they've progressed on the first-line therapy. It just means that we haven't found the right treatment. As we know, cancers are the fancy term is heterogeneous. Basically, it means that really no 2 breast cancers are the same. They all have different characteristics, different grades, different levels of aggression, and we just have to we really try to tailor the treatment to the patient. So this actually looks at all the drugs that we have had since the 1980s. I'm sure many of you recognize the names of some of these drugs, particularly those of you that have had to go through chemotherapy. But as you see, we've got many drugs for metastatic breast cancer, and the ones at the bottom, the Everolimus and the palbociclib, are what we're focused on tonight. But a lot of these other drugs, particularly the eribulin, the TDM1, the pertuzumab that have come out in the past 10 years have shown amazing survival data as far as the overall survival length of time that patients are having now that they're on these medications. So this is the nitty-gritty part. How do they work? How do these drugs help breast cancer to keep on responding to hormonal therapy? The Everolimus, or the Afinitor, inhibits a pathway that is often in overdrive in metastatic hormone receptor positive breast cancers. 70% of the cancers that are hormone receptor positive have an overactive PL3K pathway. And so, from what we understand, hyperactivation of this pathway can actually contribute to the cancers not responding to hormone therapy. The Ibrance works a little bit different, and we're going to talk about that a little bit more in a few minutes, but it actually works similar to chemotherapy in a certain way, but the effects are not quite as profound on our good cells, and it actually slows down the mitotic cycle. So it's a CDK4/6 inhibitor, and essentially, we'll talk a little bit more in depth about it when I can show you some pictures, but it helps to block a phase in when cells are undergoing mitosis or replication. And evidence suggests that hormone receptor positive breast cancer that is failing to respond to traditional therapy, tamoxifen, Femera, also depends on the CDK4 for cells to multiply. And so shutting that down is helping patients to respond for longer. So this is a really busy slide, and I'm not going to even pretend to completely explain it to you all. But if you look at, I'm going to cut the microphone off for a little bit.
This is the surface of a cell. So if you think back to junior year in high school, you did your little cellular models, maybe it was earlier than that. This is the outside of the cell, this is the inside. So in breast cancer cells, we see different receptors on the surface. They all actually have HER2 receptors. Actually, all of our cells do, but it's in the HER2 overexpressed breast cancers, there's lots of these little HER2 receptors, and the more HER2 receptors there are, the more aggressive the cancer is. So there's all these little receptors. Here we have our estrogen receptors, which are actually on the inside, but here is the mTOR PL3K pathway that actually leads to cell replication, proliferation, and from what the smart scientists that are a lot smarter than me understand, that basically there's a crosstalk in the estrogen receptors and the PL3K pathway kind of feed off each other. So basically we know when cells are not responding to anti-estrogen therapy, it's because this pathway is hyperactivated. So the estrogen receptor signaling pathway, we know because the cancers stop responding to them, we know there's some other way they're multiplying, right? They've mutated the traditional therapy. So anybody gets a free dessert tonight that can perfectly pronounce this first word right here, because I've actually even haven't heard the scientists say it because it's so long. We're going to call it PL3K. Who wants to try? Anybody want to try? Sure.
Photophatidylinosytal.
That's at least worse than another brownie, I think. Okay? I'm not going to go there. because I can't. I'm not gonna do that. So we know that it's a group of lipid kinases. Okay, wait a minute.
Let's try this.
Okay, that sounds good. Yeah, we're gonna call it PL3K, okay? And that is basically, it's a group of enzymes that regulate cell proliferation and survival. So with proliferation, we mean cells, they're keeping on living. They're surviving. They're not responding to therapy. So the PL3K inhibitors, along with anti-estrogen therapies, appear when both pathways are blocked. There's a synergistic effect that lead to cell death. So when they are working together, there's cellular proliferation and growth, but when both pathways are blocked, we're seeing that the growth is being slowed down. And so we talked about the crosstalk briefly, but you see the PL3K and mTOR pathway and then the little estrogen square, and we're seeing that basically the dual inhibition of both pathways is slowing down the cell growth. Because the estradiol, so that's our estrogen, our bodies, our hormones, whether they're still being produced by your ovaries, whether your estrogen is, you're gone through menopause and it's been produced by your fat tissues, we know that estrogen is feeding the growth of the breast cancer cells. So when it says estradiol suppresses apoptosis, that's a fancy way of saying it's keeping them from dying. All of our cells undergo apoptosis, which is known as programmed cell death, and it means that our cells undergo a normal cycle of life and death. In healthy cells, it's regulated. It occurs, it's you know, our bodies are working fine. When there is a tumor present, apoptosis gets shut off. So the normal programmed cell death is not working anymore. And we know that estradiol, or estrogen, and estrogen receptor positive breast cancer causes the cells to become more active and live longer in the breast cancers. And this is basically the same thing I just showed you, but it's in the Afinitor packaging, and it's just kind of I think it's a good simple way of showing you that blocking of the mTOR pathway and the estrogen shuts off cell proliferation and survival. So, let's move on to the next drug we're talking about tonight. Then we'll go over side effects and things at the end. The palbociclib, or Ibrance, and this is the drug that just came out in February, and it was actually given an accelerated approval because of good results in some phase 2 trials, and one of them was going on in, part of it was going on in Nashville. So, as we see our little cell cycle here. So, once again, go back to biology class, and we know what mitosis is. Well, we know cells don't just divide by themselves. There's a series of events that go on that causes mitosis. So, mitosis starts with the G1 phase, then it goes to the S phase, the G2, and then the last phase is the M phase. And it basically happens when there's a group of chromosomes in the S phase. Each of the 46 chromosomes are duplicated, and then finally they split. Everybody probably has seen that little picture under the microscope that you showed. You've seen that, you know, one cell becomes 2 cells. So the oral inhibitor, palbociclib, is a CDK4/6 inhibitor, and basically it shuts down one of the proteins that causes the mitotic cycle to go from the G1 to the S phase. There's a little bit better explanation. And I feel like this is kind of archaic, but I just took a picture of one of my nursing textbooks and put it on this slide. So,
as you see, we have early G1, that's the beginning of mitosis. And you see at the top, there is the CDK 2, 4, 5, 6, and the cyclin D. The cyclin D are little proteins that have to become active for the cell to begin to move into the S phase. The CDK 2, 4, 5, 6 are enzymes that actually shut on the proteins. So, you think of a CDK 4/6 inhibitor shuts down those enzymes, so the cells can't move to that phase. Now, we know they're still replicating, but we do know we see significant slowing down of this process. So, that's how that works. The question is, does it affect some healthy cells? And it does, and we'll talk about that. It's not as significant as chemotherapy, but it does have some issues with basically cells that turn over rapidly, like our bone marrow. It does cause some issues, and we'll talk about that. But we're also seeing that patients are gaining significant time before they have to progress when they're taking the Aferins. And this is just a slide that kind of shows the same thing as the different phases of the mitotic cycle. Dr. Daniel actually sent me this she is in a board review in Washington this week to retake her hematology oncology boards. They have to do that every so often, and so she would have loved to have been here, but she was taking that, she's with us in spirit and in her slides. So it just basically goes through that there is resistance to endocrine therapy, presents a major challenge, but we do know that the growth of hormone receptor positive breast cancer is dependent on the cyclin D1, and then the cyclin D1 activates the CDK4/6 that causes the cells to undergo mitosis, and we do know the CDK4/6 inhibitors significantly slow that down. So that's all great, but do they work? So both drugs show significant progression-free survival. However, the overall survival at this time on the drugs is not quite as compelling, but progression-free survival is significant because basically, it's buying patients a lot of time before they have to go to chemotherapy for their metastatic breast cancer. And that means less visits to the oncology clinic, less visits to the infusion room, and a lot more quality time with their families. So this is significant. It's not perfect yet, but we'll talk about the actual data here. So the Brca 2 study was a study that looked at Everolimus, which is the Afinitor, plus Aromasin. I don't know if anybody's ever been on Aromasin. It's a aromatase inhibitor that is given to patients that have had, postmenopausal patients that have had breast cancer, that shuts down. It's the same class as Arimidex, Femara, Aromasin, and basically what it does is it shuts down the body's production of estrogen in our fat tissues. So we know that women that are premenopausal are still producing ovarian estrogen. However, after menopause, whether it be surgical or natural, the only way we're still producing estrogen is basically it's made in our fat tissues. And so the aromatase inhibitors actually shut that off. So that also leads to our lovely hot flashes, joint aches, vaginal dryness, fatigue. Estrogen does a lot. It does a lot of good things besides make breast cancer cells grow. So I'm sure many of you are familiar with some of those side effects. So the reduction with the Aromasin and the Everolimus, there was essentially a 55% reduction in progression. So patients that took Aromasin alone, the median, the average progression time was around 3.8 months. And sometimes patients can progress a little bit and we watch, but any progression on Aromasin alone
In this study, and this was actually second line, patients that had already been through one line of therapy, was 3.8 months. And essentially, patients that took the Afinitor with their Romacin had double time before they progressed. So it was 7.8 months. And Dr. Yardley is actually one of the doctors at Tennessee Oncology in Nashville in conjunction with the Sarah Cannon Cancer Center. So now we're going to talk a little bit about the studies from the Ibrance. Has anyone ever heard of fulvestrant? Okay, fulvestrant is Faslodex, and it actually is an anti-hormonal therapy injection that's given to patients. It's not given to anybody that the breast cancer hasn't recurred. It's given to patients who are metastatic, and it shuts down estrogen in a little bit different process, but it's actually given in a monthly injection. You would have to get it in your oncology clinic. But the Faslodex plus the Ibrance was the first arm of the study. Second arm was just Faslodex, and they were getting a sugar pill, placebo essentially. So they were actually looking at patients with pre or postmenopausal, and you see this data was even a little bit more compelling, that the patients that were on the fulvestrant alone did have some progression. The median progression time was, so some were quicker, some were much longer, at 3.8 months, and the patients that got the new drug, the Ibrance with the Faslodex, were able to stay on it for 9.2 months, which is, almost a year without any evidence of progression. And so anytime you see a curve like this is called a Kaplan-Meier curve, and you look at a research study, whether it be on the news or in a magazine, for it to be significant, you want to see lots of space in the middle there. And so basically, this is just a curve that shows that there was significant difference in progression-free survival in patients that took the two drugs together as opposed to the one. So this is what led to the approval of this drug in February, and this is the way that we're currently giving it at Tennessee Oncology. Letrozole is Femira. It's another aromatase inhibitor. It's very similar to Arimidex, and it's something that patients have often been put on when they first recur that have hormone receptor positive breast cancer, and then many of patients take it just for 5 years to reduce the risk of recurrence. Similar type side effect profile, hot flashes, joint aches, fatigue, all the lovely things of intensified menopause. With this, it was given with the Ibrance. Now the Ibrance is given a little bit differently than the Afinitor, which is basically just you take it each day with your hormone blocker pill. The Ibrance you take for 21 days out of 28 days in a cycle, like a month, and then you stop it for 7 days. And the reason for that is because, as we talked about how it slows cell proliferation down, you actually have to kind of give the bone marrow about a week to recover on it. So you take it for 21 days out of the month, and then you take a little break, but you actually continue to stay on the Femira. In this study that was done, this was first line for patients. So as soon as they recurred, as soon as they had a diagnosis of a metastatic breast cancer or gone outside the lymph nodes or the breast, they were able to be enrolled in this trial. And in this study, the median progression-free survival time was actually 20.2 months. So that is significant. I mean, over a year and a half before they had to change therapy on the Ibrance and the Femira, where the Femira alone, it was 10.2 months. This is a really fancy slide that just basically shows you how the study was divided. They actually did test some special hormones in the part 2 of the study, but the meat of the data really came from the initial arm of the study that showed just the letrozole alone versus the Ibrance with the letrozole, which is the Femira. And once again, there was significant progression-free survival. Now, with the significant progression-free survival in these new drugs, at this point, we haven't seen major data on overall survival yet, which is really, it's the gold standard that the FDA looks for when we look at, how effective are drugs. Because as you can see, the separation is not quite as great as it is in the progression-free survival. It is significant. There's about a 3-month difference there, but they're still thinking that patients that are on these therapies, the oral therapies, are eventually going to probably have to go to chemo, but we're seeing it buys them a lot of time, and that's what we want to see. We want to see patients that are living abundantly with metastatic breast cancer, as opposed to having to go to a clinic every other week for chemo for 3 or 4 years. So we still have a way to go, but this is a good start. The side effect profile, I know that's a question that probably many of you have. So we talked about a little bit about what the side effects are just for hormonal therapy, which many of you know, hot flashes, joint pain, vaginal dryness, fatigue are the most common. I'm sure if you guys had a chance, you could probably tell me some others that you've had, many of you that may have taken these medications. But the Afinitor, the first one, the number one side effect we actually see with these patients is some stomatitis or mucositis, which that means patients that have developed sores in their mouth. It's transient and it's treatable, but it is significant. So I don't know if anyone ever had any sore mouth when they were going through chemotherapy. So you know what that feels like. It's not great. What we've seen in this drug is that a lot of times you can treat it with MD Anderson mouthwash or Magic mouthwash and it will resolve. A couple of patients on the study, though, did have to actually stop the therapy because of the mucositis, because, what good is it taking a pill if it's going to make you feel like you're on chemo? So because of the decreased cell turnover, there was a few more infections in both of the drugs, and it just basically has to do with the fact that the bone marrow wasn't acting quite like it should, and so it did weaken the immune system some. However, the infection was still not near as high as what we see with adriamycin or chemotherapy, but patients did have a little bit of immunosuppression on the drugs. The fatigue was similar actually to what we kind of see on hormonal therapy, about 30%. Most patients about 20 to 30 patients on hormonal therapy actually do report some fatigue. The pneumonitis and the angioedema at the bottom, those were less common, but I feel like we should always report them because the pneumonitis and actually in the Ibrance, the pulmonary embolism, of course, can be very significant. So the pulmonary embolism in the Ibrance, it was slightly above what would be on hormone therapy alone. However, we also know that patients that have metastatic cancer actually just have a general higher risk of having a blood clot in their lung or their leg than someone who does not have metastatic cancer. It has to do what we think is just the body kind of has some inflammation that's a little bit higher that causes the blood to be a little thicker. So some patients that have had this, of course, there was one that had a mild that was able to go ahead and continue therapy. Just they used put them on a blood thinner, but there was a patient that was significant that the therapy was stopped. The main thing with the Ibrance is if you are started on this drug, for the first month you have to come in for a weekly blood count because it really does cause some neutropenia. And neutropenia is just a low white count. Low enough that if it would continue like that, you couldn't really stay on the drug. But the really interesting thing with the Ibrance was that many of you that have gone through adriamycin, red devil chemotherapy know that you can become severely neutropenic and actually run a fever, develop infections. The strange thing about the Ibrance was that these patients did have low counts, but the incidence of actually febrile neutropenia, where it actually caused you enough to get sick, was like 1 to 2%. So we're seeing a low counts in these patients, but we're seeing it basically not make them very sick. And what patients are able to, 75% of your patients' counts will drop. However, in that 7-day break, they jump right back up and they can continue on therapy without a problem. So anemia and thrombocytopenia, which as we know is a low hemoglobin, weakness, or low platelets, which can sometimes place patients at risk for bleeding, was not near as common. We did have, Dr. Daniel and I did have one patient that had all three that was on the Ibrance. It was a patient that she had a lot of bone disease and had undergone a lot of radiation, so her bone marrow really didn't work great to begin with. And so we had to take her off it. And so that is an issue, but the majority of patients just have the low white count when they're on the therapy, don't have a problem with fevers, take a break for a week, and they're able to get back on it. The hair loss was in 17% of the patients, was a little bit of hair thinning. It was not complete grade 2 hair loss that is in chemotherapy. And then we talked about there is still some fatigue and mouth sores that are seen with both of these drugs. However, if you actually look at, if I was to put Taxol or adriamycin on the slide, you would see nearly 100% on some of these side effects. So this just looks at grade 3 and 4 side effects. I know some of you may have heard about grades. I don't know if anyone in this room was ever on a clinical trial for any of their therapies, but clinical trials, we really have to grade the side effects to report. So grade 1 side effect is, it's like, yeah, I have this, it's not a big deal. You really don't even have to treat it. Grade 2 is where I notice it, it's bothering me, I want treatment. Grade 3 and 4 are significant though. So grade 3 stomatitis would be, you're having to come into the clinic to get IV fluids because you can't eat or drink. And grade 4, it was not seen, but it would be where you actually have to be admitted to the hospital. So that just kind of tells you basically the severe side effects in the number of patients. So if you see in the Everolimus and Aromacin arm, there were 500 patients. That's the number that experienced the severe side effects. So it's low, but I think it's worth reporting if you're gonna take these drugs. And this was the same thing with the Ibrance. I talked about how, because it shuts down the mitotic cycle, the cells in the bone marrow just aren't turning over as well. And so once again, we see some of the neutropenia, low white count, low blood cells, low hemoglobin hematocrit. Basically, it just causes a little bit of suppression of the bone marrow, but once again, it's not anything like the incidence we're seeing in patients that are on chemotherapy. So that's kind of the meat of the oral drugs that I have tonight. However, a couple of things that are coming along in research are patients, still metastatic patients, but this is a drug that is actually being researched that is tailored just for patients that have a BRCA mutation. And it's called a PARP inhibitor, and it's actually seen in patients, and it's found to be active in patients that have a BRCA mutation. Is everybody familiar with what a BRCA mutation is? Most of you? It's where you have the genetic, like it's where you carry the gene that caused your breast cancer or the ovarian cancer. So they've actually identified a target in these drugs that actually goes after the defective gene. So it's found to be active in patients that have ovarian and breast cancer that are due to the BRCA mutation. So it is showing good data. It's not something that we have approved and are given right now, but that's kind of something that's coming along the pipeline. So I'm going to go ahead and give you my references. I know you guys, I want to scribble those down because you're going to probably check them tonight, right? And I've left some brochures back on the table. There's some breast cancer patient resources. And then if anyone wants a copy of my slides, if you're a nerd like I am and actually want to look up a little bit more about the cell cycle tonight, I sent them to Tanya and she's more than welcome to distribute them to the group. But now I would like to answer any questions you guys have. Yes, ma'am.
I was on the Finitor, could not do it. With the Ibrance, what's the statistics as far as people being able to stay on the drug and not getting off because of the side effects?
Do you mind if I ask you what kind of side effects did you have on the Afinitor? Was it the stomatitis?
I had that, but I just felt crummy, diarrhea, nausea, bloating.
So it was kind of like chemotherapy, where it just made you feel like correct.
Feel like chemo.
Chemo, like
Yeah, oh yes,
chemotherapy.
it felt like the first day after chemo,
Okay.
but it kept going.
So, like I said, the Paloma study that we had, patients, there was a lot of patients that were on it with the Femera for up to well over a year. We've just had a few patients on the Ibrance and they felt fine, but it's just the counts that we have to watch. In fact, I feel like the Ibrance is a little better tolerated as far as just how a patient feels. But, you know, I'll be honest with you, if you had this, because they still work on the same type on the cell cycle, you probably would have a risk of having some of the same side effects. The stomatitis, we're not seeing near as much with the Ibrance as we are with the Afinitor, but the fatigue, I don't know if, did you know if you had any problem with your counts while you were on the Afinitor or anemia? You just felt tired. So you could, you know, it could be possibly an option for you, but be cautiously optimistic with it if you did have problems with it. Yes, ma'am.
I was on Finitor and felt just like she did, and then I went on Ibrance in the first of March, and I just 100% feel much better.
Well, there you go.
And,
She answered your question better than I did.
And it actually went up like 2 or 3 points.
That's interesting.
So I need to go down to that. And I
So-
still had the low count.
Do you feel like have you, even though you have the low counts on the Ibrance, do they bounce right back up during that 7 days to where you're able to?
Well, I usually don't see the doctor during that 7 days that
Okay.
I'm off. So, but she doesn't worry about my count. She knows they're low, but
She knows they're low, but-
she isn't that worried.
And a lot of it is just because the research shows that so many patients have low counts, but interestingly enough, they didn't have a problem with it.
Right, that's me. For once in 2.5 years, I finally feel good.
Well,
Good for you.
she's our walking testimonial for Ibrance tonight. Yay.
Yeah.
Yes, Mr. Clarence.
Yeah, I have a question. I'm taking it to Martha, and I wonder, is this still a good drug or a drug to take?
It is the most, tamoxifen is 100% the most tried and true medication for hormone receptor positive breast cancer. It's the oldest. It's been around for over 40 years actually. And if you tolerate it and it's working, it's a great drug. As you know that there is a slightly high risk of blood clot or stroke on the tamoxifen. Slightly high risk of uterine cancer, which you don't have to worry about. But if you tolerate it and are responding to it, it's a great drug, and it's a favorite of Dr. Daniel to use. So yes, it's still active and it's still thought to be a good drug, and it's a cheap drug. That's another thing with the Ibrance and Afinitor. As they're new, they've got great patient assistance programs to help folks out, but they're expensive. Yeah, very expensive. Yes, ma'am.
Do you know if there are any new drugs in the pipeline for triple negative or HER2 positive?
It's a great question. So we'll talk about that in a few minutes. So her question was, do you know if there are any new drugs coming down the pipeline for triple negative or HER2 overexpressed? And the answer is yes. And so we'll take just, I don't want to saw a couple of little sleepy eyes, so I don't want to bore you anymore. But so we'll talk a little bit about, have you heard of the TDM1? So that's our big one for HER2 overexpressed breast cancer. So TDM1 is now approved as a brand name Kadcyla for patients that have metastatic HER2 overexpressed breast cancer, and it is, we found, very active. And what it does is basically, it's got a molecule with an old toxic chemotherapy attached to it, but it's actually kind of like a drone, and it actually targets only the HER2 protein. So we're seeing patients that have been on it for a couple of years that have not progressed at all. So it's great. So Sarah Cannon has a trial going on now, though, that's actually looking at giving it to patients in the pre-op and adjuvant setting, so before they ever progress. So we're actually looking at seeing if maybe the Kadcyla or the TDM1 up front actually keeps HER2 overexpressed patients from ever recurring. And then many of you have probably also heard of the Brca, which, I mean, that came out in the news that there was like a 16-month survival benefit in that. As far as triple negative goes, there's a lot of studies. There's nothing really new yet that has been FDA approved, but there's a couple of very exciting drugs that have research trials going on. One is a drug that's similar to the Kadcyla, and our trial that we have it going on at Nashville is just called MM302, and it basically has adriamycin attached to a molecule that's supposed to hit only breast cells without hitting healthy cells. So there's a lot of research going on. The HER2, I think right now we're getting closer to finding something that really works. Triple negative, I think we still have a ways to go, but there's several trials that are available.
What's the toxic drug that she liked with the Kadcyla? Toxic drug that...
It's an old nitrogen mustard. Yeah, so...
really old.
Yeah, really old, but really active. And evidently, we have patients that it really is only affecting the cancer cells, which is awesome. That's what we want. We want drugs that are going to kill the bad guys while protecting the good guys. That's, you know, so, yes, ma'am.
How does 5FU work? 5FU.
How does 5FU? It works, from what I understand, basically similar to the CDK4, where it basically inhibits with DNA replication. And another drug, I don't know that many of you know, are you actually referring to the IV 5FU or the oral 5FU? So we give IV 5FU a lot for patients that have colon, esophageal, pancreatic cancers, but there's also an oral form, Xeloda or capecitabine, that we have a whole lot of patients on for metastatic breast cancer that do really well on it too. The good old side effects, it does cause some patients it causes some low counts, some patients it can cause some diarrhea, and it's one of the ones that can cause what you call the hand and foot syndrome. So when you're on it, sometimes you'll kind of have some tenderness in your hands and feet. But I have several patients that, I mean, I feel like they live a pretty good quality of life. They come in every 3 weeks. We check their counts. It's oral, even though it's not a new oral, so I didn't really focus on it tonight, but it's been around a while, but it's given to a lot of breast cancer patients, and it actually is indicated for triple negative too. Patients that tolerate it tend to tolerate it great and can stay on it for a while. And usually it's given where you take it for 2 weeks on, 1 week off. And the dose varies highly, up into 500 milligrams twice a day, up to 2,000 milligrams twice a day. But it's basically oral 5FU.
And his name is?
Xeloda. It's X. It's X-E-L-O-D-A. So, any other questions? Well, I just want to thank you for being here. I want to thank you for coming out and learning about your disease. You are the reason I love coming to work every day. You're the reason that I get excited about reading about breast cancer, because it is exciting to serve a population of people that 30 years ago was a disease that could be very devastating and still can be devastating, but there's a lot of hope. And I just want to thank you so much for having me.
We appreciate you so much and taking time out of your schedule to come and talk with us. And I know you've got 2 young ones at home, and especially this week getting started back in school and everything, and it's a little crazy, but we really do appreciate you coming today. I do have one little piece of business, yeah. Everybody likes this part. So we've got a couple of little door prizes right now. So everyone's got a little sticker on their evaluation.